Hello, my name is Carrie Schaefer, and I will be speaking with you about adult congenital heart disease. I'm a cardiologist here at the Boston Adult Congenital Heart Disease Group, located at Boston Children's Hospital and Brigham and Women's. Adult congenital heart disease is actually fairly common. Congenital heart disease is the most common birth defect, occurring in roughly 8 in 1,000 live births worldwide. This means that over 40,000 children are born with congenital heart disease in the United States each year. Due to advances in surgical techniques, survival has dramatically improved, such that 95% of babies born with non-critical congenital heart disease will reach adulthood. Almost 70% of those with critical congenital heart disease, such as these conditions shown here, will also reach adulthood. As a result, there are 1.4 million adults living in the United States with congenital heart disease, and this number continues to increase. The most common defect seen in childhood is ventricular septal defect. However, these spontaneously close in many children, particularly those with muscular VSDs, which we'll discuss later. In adulthood, ACHD admissions are most commonly associated with atrial septal defects, congenital aortic valve disease, mainly aortic stenosis and regurgitation, ventricular septal defects, coronary anomalies, and tetralogy of Fallot. As some of these topics will be discussed elsewhere, I will focus on atrial septal defects, ventricular septal defects, tetralogy of Fallot, as well as a few other common conditions. Genetic associations are commonly seen in congenital heart disease. 10 to 15% of patients are found to have chromosomal associations, such as trisomy 21, trisomy 18 and 13 less commonly, as well as the 22q11 microdeletion, also known as DeGeorge syndrome. Patients with these chromosomal abnormalities are often found to have congenital heart disease. Additionally, individual genes have been associated, and we'll discuss these as we go through the individual lesions, but I wanted you to have a list of the most common associations, including TBX5, NKX2.5, GATA4, and Notch1. Notch1 has been featured in recent publications as it is associated with both the common anomaly of bicuspid aortic valve as well as other left-sided lesions, such as hypoplastic left heart syndrome. Now we will discuss specific lesions. As I mentioned earlier, I will highlight the most common lesions. However, adult congenital heart disease is a very heterogeneous population, and each individual lesion deserves specific assessment. Ventricular septal defects are among the most common types of defects in both adult and childhood. As I mentioned earlier, childhood associated congenital heart disease is most commonly VSD. So the type of VSD the patient has really just relates to the anatomy of the location in the ventricular septum. Muscular defects are seen here when they're unassociated with any of the valves. If the ventricular septal defect is close to the tricuspid or mitral valves, it's called an inlet VSD. If the patient has a defect that's close to the great arteries, it's most commonly referred to as an outlet VSD. However, it has several different names depending on the institution, can sometimes be called subarterial, subaortic, or supracrystal. And that's because the crista supraventricularis is located just here. As I mentioned, it's very common in pediatric congenital heart disease, and nomenclature is based on the institution. We categorize ventricular septal defects on echocardiography, and one of the categorizations is based on whether or not the defect is restrictive. So a restrictive defect is one that has significant narrowing and limits blood flow, often has a gradient. The categorizations vary between echocardiographic textbooks and guidelines. The ACHD guidelines from 2008 refer to the restriction based on a pressure gradient of less than or greater than 20, as well as the size relative to the aortic annulus. VSDs are associated with several different complications and associations. The first thing to understand about ventricular septal defects and all shunt lesions is what drives shunting. Shunting is due to the downstream compliance and resistance. compliance of the downstream ventricles and resistance of the downstream vascular beds. So in a ventricular septal defect, compliance of the right ventricle relative to the left ventricle is what drives ventricular level shunting. And the pulmonary vascular resistance is what drives shunting across the VSDs at the resistance vasculature level. So if the PVR is elevated, then that would potentially drive the shunt across the VSD towards the left ventricle. If the systemic vascular resistance is lower. This is an important concept and something that's commonly missed because people think that shunting is secondary to pressure. Pressure is certainly an outcome that results in the changes in compliance and resistance. As a result of long-term shunting, patients can get several consequences. Because the majority of shunting, particularly in membranous VSDs, occurs in systole, LA and LV volume loading can be seen frequently. This is a sign that there's a significant amount of shunting across the ventricular septal defect. If the patient has high flow for a long time, the patients can develop Eisenmenger syndrome, which I'll discuss later. Associated lesions are seen 50% of the time in patients with ventricular septal defects. The most common associations include ASDs, pulmonary stenosis, double chamber right ventricle, and left superior vena cava. I'll discuss most of these individually. And I should also mention that a list of abbreviations is seen at the end of this presentation. Physical exam findings seen in ventricular septal defects include a holosystolic murmur, particularly at the left sternal border, that becomes slightly less loud as the end of systole approaches. The most common type of VSD is the membranous VSD. The effect of the VSD relates to the proximity to the tricuspid and aortic valves. If you'll remember a few slides back, the membranous septum is located just at the border between the tricuspid valve and the aorta, at the very top of the ventricular septum. Several different types of physiology are seen. An example of this is the so-called pseudo-closure of the ventricular septal defect as a result of the tricuspid valve adhering to the defect. It's sort of pulled into the defect as blood flows across it, and the tricuspid leaflet can be distorted into the defect. As a result of this, as you might imagine, the tricuspid valve is abnormal and may either have regurgitation or be at increased risk for endocarditis. A rare but sometimes tested type of defect is called the Gerbode defect, which occurs sort of in the membranous region and can result in shunting directly from the left ventricle to the right atrium. Here's an example of a ventricular septal defect in the membranous location. This is a transthoracic echo shown in the parasternal long axis view. As you can see here, there's a small defect in the thin membranous portion of the ventricular septum. As you can see, the defect is restrictive as there is turbulent flow with a very high Nyquist limit. As well, you can see that the predominant flow goes from the left ventricle to the right ventricle, left to right shunting. There are several other types of ventricular septal defects. Muscular defects that I've mentioned earlier occur commonly in childhood and may close on their own. This is the only type of defect that's amenable to percutaneous closure. This is also a type of defect that can occur in an acquired condition, as patients with severe myocardial infarctions can sometimes develop muscular VSDs. Outlet VSDs is the type that is most frequently named differently depending on the institution, and can be associated with aortic and pulmonic valve dysfunction, as it's located just below the aortic valve. So here's an example of a parasternal short axis image where you can see the aortic valve in the center and the ventricular septal defect occurring just below the aortic valve annulus. The third type of defect is the so-called inlet defect. This is a defect that occurs near the AV valves. So in this axial view on a cardiac MRI, you can see that the defect, shown here with the red arrow, is at the top of the ventricular septum near the mitral valve and the tricuspid valve. It's often associated with a primum ASD, which we'll discuss next, which is part of the AV canal defect. It is very common to see this type of defect in patients with Down syndrome, trisomy 21. Double chamber right ventricle is a unique type of configuration that occurs in up to 10% of ventricular septal defects. Often associated with membranous defects, the mechanism is the hypertrophy of RV muscle bundles, just inferior to the RVOT. These are sometimes difficult to diagnose as they have a systolic murmur similar to pulmonary stenosis. Here's an example of a still frame of a parasternal long axis view. Somewhat grainy of an image, but I'll show you a few more. This is the LV, left atrium, and aorta. As you can see here, there's turbulent flow, and just a lot of turbulent flow out into the RVOT. This is the spectral Doppler across that region, and really not diagnostic as to whether or not there's just a VSD or also associated RVOT obstruction. And so a cardiac MRI was performed in this patient, and as you can see quite dramatically in systole on this short axis view, left ventricle, right ventricle, there are muscle bundles just inferior to the pulmonary valve, which are obstructive in systole. In diastole, you can see the muscle bundles, but it's much less dramatic. And in fact, this patient had significant stenosis across the RVOT muscle bundles, consistent with double chamber right ventricular physiology. This defect is commonly missed in adult cardiology labs because it typically is misdiagnosed as either pulmonary hypertension or pulmonary stenosis. And this is important because surgical management is required as opposed to catheter-based or pharmacologic therapy. If patients have a large defect that's unrepaired in adulthood, they can develop Eisenmenger syndrome. Eisenmenger syndrome occurs as a result of high pulmonary blood flow, which increases pulmonary pressures. Over time, the patients develop endothelial damage, in particular of the pulmonary arterioles. Hyperproliferation and hypertrophy of the smooth muscle, as well as the intima media thickness, can result in vasoconstriction and increased pulmonary vascular resistance as a result of plexiform lesions. This is a prototypical schematic which shows the typical onion skinning, the media intima thickness that occurs in Eisenmenger syndrome. Incidentally, this is also the same physiology that occurs in pulmonary arterial hypertension. A classic finding of Eisenmenger syndrome is shown here, the significant clubbing of the lower and upper extremities. Clinical pearls to remember about Eisenmenger syndrome. First, they can be treated by pulmonary vasodilators. It's a class 1 indication to treat these patients with bosentan, given that there is a large trial showing benefit in these patients, potentially as a result of the vasoconstrictor release process. It's also been reported that patients with Eisenmenger syndrome have poor outcomes if they are iron deficient. As you might remember, these patients often have a very high erythrocyte count and have a higher iron requirement. It's also important to remember that these patients are at increased risk for paradoxical embolism and infection, both endocarditis and abscesses. So what do the guidelines say about ventricular septal defect management? First, closure is indicated in the setting of a high QPQS and the setting of volume overload. And essentially something to remember about all of the guidelines in congenital heart disease is that by and large, they're based on physiologic effects of the shunting or an anatomic abnormality, as well as symptoms. This is one of the only times that shunting results, or that congenital heart disease recommendation guidelines include closure in the absence of symptoms. QPQS is an important concept to understand in congenital heart disease. The formula is shown here. This is the quick formula. There's a more extensive one that takes into account hemoglobin and cardiac output. But this ratio relates the amount of blood flow that goes through the lungs versus the systemic circulation and can be calculated by taking the differences in aortic and SVC saturation divided by the difference of the pulmonary vein and pulmonary artery saturation. Other indications for closure include history of endocarditis, thought to be secondary to ventricular septal defects, lower shunts, but in this presence of low pulmonary artery pressures, as closure is not indicated in patients who have Eisenmenger syndrome or irreversible pulmonary arterial hypertension. Percutaneous closure is only an option predominantly in the muscular defects, particularly when the tricuspid and aortic valves are remote. Outcomes after repair are variable, and in a large recently published study of 40 years of follow-up, you can see that survival is quite high. But it's important to note that arrhythmias and endocarditis are still seen. Let's move on to atrial septal defects. These are quite common both in childhood and adulthood, given their very high survival rate both with and without closure. Genetic defects associated with ASDs are shown here. The majority of patients are asymptomatic in childhood, but may present in childhood or adulthood with nonspecific symptoms such as fatigue, dyspnea, arrhythmias, murmur, or paradoxical embolism. It's very uncommon for patients with ASDs alone to present with Eisenmenger physiology and is only seen in 5 to 10% of cases. Physical exam findings frequently tested on include RV heave or prominent RV impulse, a fixed split S2. Now this is because there is minimal change in the timing of S2 with respiration, so that's the absence of physiologic splitting. Systolic ejection murmurs are also commonly seen, both because of increased flow across a pulmonary valve, as well as due to pulmonary stenosis. Atrial level shunting comes in 2 different varieties. The actual atrial septal defects located in the atrial septum, commonly seen in the secundum location and the primum location. ASDs of the secundum type are far and away the most common, seen 75% of the time. Primum defects, as I mentioned before, are seen less commonly or often associated with other endocardial cushion or AV canal defects. Other types of defects that are at the level of the atria and have similar physiology to atrial septal defects are the venous septation defects. These occur at the level of the SVC and IVC, and essentially it's unroofing of the pulmonary veins as they pass behind the SVC or IVC. The coronary sinus can also be unroofed. The collection of these defects have similar physiology, which is typically left to right shunting at the level of the atria, causing right ventricular and right atrial enlargement. This can be seen on echocardiography. As you see in this apical 4-chamber view, there's right ventricular and right atrial enlargement. This patient has a severe amount of those 2 things, as you can see that the RV is apex forming in this example. In this zoomed up color flow view, you can see flow across the secundum defect in this patient at the level of the atria. Typical ECG findings include right axis deviation and an RSR prime, particularly in V1 and V2. This is seen in secundum type defects, but also in venous septation defects, as the physiology is similar. Unexpectedly, left axis deviation is seen in primum ASDs because of a congenital malformation of the conduction system in these patients. So what do the guidelines say about ASDs? It's a class 1 level of evidence B to close the ASD in the setting of dilation with or without symptoms. Secundum defects can be closed percutaneously, but surgical repair is required for the venous septation defects as well as primum ASDs. Benefits are variable based on the review articles and published literature that you look at. Exercise capacity is thought to improve universally across all patients who have ASD closure. And there is likely a decreased risk in atrial arrhythmias and pulmonary hypertension later on, although this probably relates to the timing of ASD closure. RV size certainly decreases in all patients with ASD closures in the absence of pulmonary hypertension, and it has been reported that the LV ejection fractions improve after closure, which is thought to be secondary to the RV-LV interdependence. Closure is associated with complications, but less than 1% risk. An example of percutaneous closure is shown here. So this is a patient who had a secundum atrial septal defect that had a percutaneous clamshell type device that closed the defect. And the important thing to understand about percutaneous closure is that they are continually at risk for complications. In particular, which I think is partially shown here, is that the device itself is abutting the aortic annulus. As a result of repeated heartbeats and trauma to that area, these patients can have device erosion, although it's quite uncommon. After ASDs are closed, patients should all be followed given the fact that they will always be at increased risk for atrial arrhythmias and a slight increased risk in pulmonary hypertension. Percutaneous closure, as I mentioned, erosion is the key thing to think about. It's very uncommon, 0.3% at most. But it's important to know which patients are at higher risk. These include patients that have deficient aortic rims, particularly less than 5 millimeters. If, when the ASD device is placed, the device is seated in a very compliant structure, meaning that it's very easily stretched, then these patients may be at increased risk for erosion as well. These are just two criteria that were found in the circulation articles shown here. The ASC guidelines are excellent with regards to timing of follow-up as well as suitability for percutaneous closure, and I would refer you to those for further information. I'd like to spend just a little bit more time reviewing the AV canal defect family. As I've mentioned before, it can include a primum ASD, an inlet VSD, but also can include valvular dysfunction, including a cleft mitral and cleft tricuspid valve. What's meant by cleft is really just that the anterior leaflet, for example, has two components in the setting of cleft mitral valve. And this is as a result of the fact that the congenital anomaly is failure of the endocardial cushion to form completely. And when that happens, all of the structures seen in the very center of the heart can be abnormal. If the patient just has an ASD and a cleft mitral valve, it's sometimes termed a partial AV canal defect. But if the patient has an ASD, cleft mitral valve, and an inlet VSD, it would be diagnosed as a complete AV canal defect. Cleft tricuspid valve is very uncommonly seen and does not affect the nomenclature. As I mentioned, and just because I want you to remember that it's a highly testable question, left axis deviation is seen in patients with AV canal defect, despite the fact that they may have many reasons for right axis deviation. It's commonly seen in trisomy 21 and requires surgical repair. There are no percutaneous options for these patients. Not mentioned on this slide, but also important to remember, is that these patients are at much higher risk for pulmonary arterial hypertension. Just wanted to show you an example of a cleft mitral valve. So on this parasternal short axis, you can see we are at the level of the base and the mitral valve is shown here. As you can see, there are two components to the anterior leaflet of the mitral valve. You can see that there's regurgitation through that cleft, which is commonly seen. I'd like to now move on to right ventricular outflow tract obstruction. I'll talk about two lesions, pulmonary stenosis and tetralogy of flow. Pulmonary stenosis is actually quite common and seen in 10% of patients who are diagnosed with congenital heart disease. It's commonly associated with Noonan's, Williams, and Alagille syndromes, and can be associated with atrial septal defects. Follow-up is recommended in the 2008 guidelines as being every 2 to 5 years in moderate defects, and if higher, balloon valvuloplasty is recommended. The 2018 guidelines are similar but slightly different to this, and so I would refer you to those for subsequent management. Pulmonary stenosis has a very unusual type of exam. There's a systolic ejection murmur as well as a systolic ejection click, which decreases with inspiration. It's one of the few types of physical exam findings on cardiac auscultation that actually decreases. And it's important to note that the timing of the click actually predicts the severity of the pulmonary stenosis. The second type of right ventricular outflow tract obstruction I'd like to discuss is tetralogy of Fallot. This, while uncommon, occurring at 0.04% of live births, is the most common type of complex congenital heart disease. It's seen both in the genetic associations shown here, as well as in DeGeorge patients, the microdeletion of the 22nd chromosome, as well as trisomy 21, Down syndrome. Most of these children present with cyanosis, and it's very uncommon to present in adulthood. One of the most important things to know about tetralogy of Fallot is the fact that it is actually a single issue, the anterior displacement of the infundibular septum, that results in the 4 components that are seen on echocardiography as shown here in this diagram. So the anterior displacement of the infundibular septum results in pulmonary stenosis, right ventricular hypertrophy, the ventricular septal defect, because that component has shifted, as well as the overriding aorta, because it's not held in place by that ventricular septum. Tetralogy of Fallot exists on a spectrum, anywhere from mild pulmonary stenosis to complete atresia of the pulmonary artery. It's important to note that outcomes both in childhood and adulthood relate to the severity of pulmonary stenosis or atresia. Patients who've had repaired tetralogy of Fallot have several different types of issues, and 4 are shown here. Pulmonary regurgitation and right ventricular dilation is probably one of the most common indications for surgery in patients with repaired tetralogy of Fallot. Timing of closure will be discussed, but it's somewhat variable based on the institution. Atrial and ventricular arrhythmias are commonly seen, and some patients may be at increased risk for sudden cardiac death. Primary prevention ICDs can be placed, but are uncommonly done so given the fact that they are also at increased risk for atrial arrhythmias and inappropriate shocks. I would there again refer you to the 2018 guidelines for further discussion. Left ventricular dysfunction is also seen in patients with tetralogy of Fallot, particularly those who had both late repairs and those who have severe right ventricular dilation. 2 common associations that are very important for adult cardiologists to know are both that tetralogy of Fallot patients have anomalous coronaries up to 10% of the time, most commonly the left anterior descending going across the RVOT from the right coronary ostium, as well as right aortic arch, which can occur in up to 25% of patients. Both very important to know, both for evaluation with coronary angiogram as well as further evaluation such as pacemaker placement or arterial cannulation. So when should patients have a pulmonary valve replacement? This is an area of ongoing and extensive research. Certainly, severe pulmonary regurgitation in the setting of symptoms or exercise intolerance is a class 1 indication. Class 2 indications could be related to RV dysfunction and enlargement, as well as RVOT obstruction. These guidelines change slightly in the guidelines that will be published in 2018. Other things to know about pulmonary valve replacement is that patients do better if their pre-op peak VO2 is higher and their VEV-CO2 slope is lower. Right ventricular dysfunction and RVH also predict outcomes, both with regards to pulmonary valve replacement and arrhythmias. So what are the options for percutaneous closure versus surgical closure? Percutaneous closure is certainly increasing in frequency because of its ease of use. Melody valves have been approved, as well as Edwards Sapien valves, but it's important to remember that the RVOT conduit dimensions are important to understand prior to valve replacement. Stent fractures and embolization can be seen, and unfortunately, patients with Melody valves have been reported to have an up to 10% risk of endocarditis. Extremely elevated and important to remember as you follow patients with tetralogy of Fallot after Melody valve placement. Now I'd like to move on to a few other types of congenital heart disease that you might encounter both as you're studying for the boards as well as in clinical care. One of these is probably the second most common type of complex congenital heart disease, transposition of the great arteries, often called TGA. Now, transposition of the great arteries comes in two general categories: D-loop transposition, which is really just the great arteries being in the wrong location. Right atrium, right ventricle are in the right location, as well as the left atrium and the left ventricle. However, the aorta arises from the right ventricle, which is not compatible with life and requires surgery, which we'll discuss. A much less common type of congenital heart disease with transposition is the so-called L-looped or corrected transposition. This is called corrected because physiologically the blood goes in the right location. Blue blood from the systemic veins goes into the left ventricle and out into the pulmonary artery. Unfortunately, that means that the systemic ventricle is the right ventricle, which is prone to failure. For patients that were born with D-loop transposition, sometimes called complete transposition, who were born before 1985 often got what's called the atrial switch procedure. This is because the procedure to switch the great arteries was not able to be performed safely before 1985, and as a result, these patients got atrial switches, which really just means switching the blood coming from the superior and inferior vena cava to the left ventricle, which could then pump into the pulmonary arteries. Therefore, the blue blood got to the lungs. Unfortunately, these patients are left with a systemic right ventricle. Here's an example of an echo with a patient who has atrial switch. As you can see here, flow from the pulmonary veins goes across this baffle into the formerly known as right atrium, now called the pulmonary venous atrium, into the right ventricle across the tricuspid valve. As you can see here, and is very common in adults with atrial switch procedures, there's significant dilation of the right ventricle. And as you can probably predict, there's malcoaptation of the tricuspid valve as well. Here's just a diagram showing the pulmonary venous blood and the systemic venous blood here in blue. Outcomes after transposition of the great arteries with atrial switch procedures are not great. At 30 years, there's a 40% mortality rate in some studies. Outcomes are better in patients who have pulmonary stenosis, but much worse in those with associated defects, such as VSDs. Sudden death and heart failure are the most common causes of death, and unfortunately, only 40% of patients are in sinus rhythm at 20 years. Baffle leaks, as you might imagine, this surgically created tunnel from the pulmonary veins to the right ventricle and from the systemic veins to the left ventricle, is prone to both leak and stenosis. In patients that had surgical repair after 1985, the outcomes are much better. They had what's known as the arterial switch procedure. So the great arteries were switched. The pulmonary artery was brought forward and anastomosed to what used to be the aortic valve and is now the neopulmonary valve. And the pulmonary valve, now known as the neo-aortic valve, is attached to the aorta. So just to clarify, the pulmonary artery blood flow is restored to the right side of the heart. Patients after arterial switch do quite well. However, there are several different complications we are just now seeing, given the fact that we don't have that many years of follow-up on these patients. Pulmonary stenosis is seen in about 20% of patients, but not often to be significant. Aortic dilation, on the other hand, is quite common. We have not seen an increased risk of dissection, but we have seen an increased risk in aortic regurgitation. Coronary reimplantation can be complicated, with 5 to 10% of patients having coronary reimplantation complications. This relates both to the very small size of the coronaries at the time of reimplantation, as well as the fact that coronary artery anomalies are very common in D-loop transposition of the great arteries. As you can see here, there are several different configurations that can be seen in transposition of the great arteries. Something to refer to before you do your first angiogram on a patient after arterial switch. The next defect that we'll discuss is coarctation of the aorta. Coarctation of the aorta is seen when there's a narrowing in the descending aorta just past the left subclavian artery. The most common location for coarctation to occur is just near the ductus arteriosus. This results in a decrease in blood flow to the descending aorta. It occurs in approximately 5% of those who have congenital heart disease and is seen in 0.4% of live births. Most commonly, it's diagnosed in childhood with hypertension or heart failure. However, it can be a cause of secondary hypertension in adults, and it's important to evaluate this in patients presenting for initial evaluation of hypertension. Patients with Turner syndrome and DeGeorge syndrome, the 22q11 microdeletion, which I've shown you different ways to hopefully help you remember that DeGeorge syndrome is associated with many types of congenital heart disease. The exam is quite typical, including continuous murmurs in the back. This is because collaterals form from the subclavian artery, sometimes from the carotid or the mammary arteries, to perfuse the lower extremity to ensure that the patients have adequate blood flow to all of the regions supplied by the descending aorta. As a result, patients with severe coarctation can have an extensive web of collaterals. One finding is very classic, the radiofemoral pulse delay. This is because there is a delay in the blood flow from the aorta, ascending aorta to the descending aorta, and the femoral pulse may occur much later than expected. The reason why it's great to check the radial artery is because the radial artery is roughly the same distance from the heart as the femoral artery, and there should be no delay in the impulse felt on physical exam. Another commonly assessed way to diagnose coarctation is by checking both a right arm and right leg blood pressure. If those two blood pressures are similar or the right leg is higher, that excludes a significant coarctation. However, patients who have much lower right leg blood pressure should be evaluated further for coarctation. Echocardiographic assessment is commonly performed. One of the things that patients often get is an evaluation by the suprasternal notch to visualize this component of the aorta. However, in adults, it's very difficult to get routinely an excellent view of this, and so I would recommend that you look at the abdominal aorta. Shown here is a pulse wave Doppler of the abdominal aorta, shown with the pulse upstrokes. As you can see here, quite abnormally, there is diastolic forward flow seen in the abdominal pulse wave Doppler. This is very uncommon in any other condition and is virtually diagnostic of coarctation or an aortic obstruction. This is also something very easily testable. When you evaluate a patient for coarctation, it's important to remember that the patients, both repaired and unrepaired, have a higher incidence of mortality than the general population. Repair is performed to decrease the risk of hypertension or to improve management of hypertension. Repairs include surgical as well as stent repair. But it's important to remember that hypertension is still commonly seen in these patients and is the greatest risk for increased mortality and prevalent in 75% of patients by the age of 50. Bicuspid valves are also commonly seen in at least 50% of patients with coarctation and often associated with aortic dilation. You can also remember that bicuspid aortic valves are associated with coarctation. So if you see a patient with bicuspid valve, 10% of the time they'll have a coarctation. If you see a coarctation, 50% of the time you'll see a bicuspid aortic valve. Other associations include mitral valve anomalies and the commonly seen Schoen complex, which includes subaortic stenosis and supramitral stenosis, as well as parachute mitral valve. Coronary artery disease and atherosclerotic cardiovascular disease is more prevalent than expected in coarctation patients, although the majority of the reason for this is secondary to the uncontrolled hypertension in these patients. That concludes my review of congenital heart disease lesions. I'd like to leave you with a few summary topics. First, remember that over 1.4 million adults live with congenital heart disease in the United States, making it a very common issue in the general population and in your cardiology clinics. Most commonly encountered diagnoses include ASDs, VSDs, and tetralogy of Fallot, as well as congenital AS and coronary anomalies. Management, as I hope has been reinforced throughout the talk, is that it really relates to the anatomy and prior repair as well as shunting and valve dysfunction. I would remind you that ASDs and VSDs are closed based on the effect of shunting as well as symptoms and local effect. Tetralogy of Fallot, pulmonary valve replacement, is done as a result of right ventricular dilation in the setting of pulmonary regurgitation. Let's move on to the questions. Here is a patient that I recently saw in the emergency room. He's a 24-year-old man who presented with new onset diabetes and diabetic ketoacidosis. On physical exam, he had a systolic murmur with an early ejection click. It decreased with inspiration. The most likely diagnosis is tetralogy of Fallot, double chamber right ventricle, valvular pulmonary stenosis, bicuspid aortic valve, or Epstein. The most common diagnosis is valvular pulmonary stenosis. As I mentioned, a systolic murmur and an early ejection click, which decreases with inspiration, is very likely to be pulmonary stenosis. The click of valvular pulmonary stenosis is quieter with increased blood flow and predictive of severity. If it occurs early in systole, it's more likely to be severely stenotic. This is a diagram from Moss and Adams which shows the timing of the click related to the severity of disease. So the reason why the other answers were incorrect are shown here. Tetralogy of Fallot was incorrect because these patients would have also had the murmur, the holosystolic murmur of a VSD. Double chamber right ventricle was not correct because it is not associated with an ejection click. It is also associated with VSD, and so the VSD murmur should have again been heard. Bicuspid aortic valve patients certainly can have a systolic click, but they do not have one that decreases with inspiration. Epstein anomaly, an anomaly I haven't discussed, is the apical displacement of the tricuspid valve. This is as a result of the failure of the septal leaflet to come free of the ventricular septum. As a result, they have severe tricuspid regurgitation and often a very small right ventricle. These patients have a split S1 due to the abnormal closure of the tricuspid valve and systolic regurgitation murmur consistent with TR. Another finding that is commonly seen is the so-called sail sound, which is an early systolic snap that occurs as a result of opening of the tricuspid valve. The final question is shown here. A 25-year-old woman presented to the emergency room with palpitations and lightheadedness. She has a 2 out of 6 holosystolic murmur at the apex and a fixed split S2. She has a syndromic appearance. This ECG was found in review of her record, the baseline ECG. The defect she has is most commonly associated with which syndrome? Noonan, Down, DeGeorge, Turner's, or Schoen complex? The answer is Down syndrome. That's because this patient has an AV canal type defect. The patient's history is consistent with a shunt lesion. The physical exam in particular with the fixed split S2 is consistent with a shunt, and the ECG is consistent with left axis deviation. So the patient had a cleft mitral valve and the holosystolic murmur associated with mitral regurgitation. The patient had left axis deviation due to the abnormal conduction system in AV canal defect patients, as well as the typical fixed split S2 seen in atrial level defects. These are all suggestive of a cleft AV valve, primum ASD, a partial AV canal defect. Down syndrome is most commonly associated with these defects. Therefore, Down syndrome is the correct answer. Noonan syndrome is associated with pulmonary stenosis, but not necessarily associated with the AV canal type defects. And hypertrophic cardiomyopathy can also be seen in Noonan syndrome. DeGeorge syndrome, which I've mentioned several different times, the 22q11 microdeletion, is associated with a lot of different types of congenital heart disease, just less commonly with the AV canal type. It is most commonly associated with tetralogy of Fallot. So if the patient had had tetralogy of Fallot, the correct answer would have been DeGeorge. Turner syndrome, which is the XO chromosomal configuration, is commonly seen in coarctation. Schoen complex actually isn't a systemic syndrome, so it was a bit of a trick I gave you. These patients just have a series of defects. Left-sided cardiac obstruction, including supramitral ring, parachute mitral valve, subaortic stenosis, and coarctation. Here are some examples of the references you might use.